So I'm here in Chicago for ASCO 2014. It's been a very, very exciting year for oncology in general, but in particular in the domain of renal cell carcinoma. Really honored today to have my colleague here, Dr. Sonpavde, who's an associate professor at the University of Alabama. Guru, thanks so much for joining me.
Thank you for inviting me.
Question for you. So, patient comes to your clinic with newly diagnosed metastatic disease. What is your typical sequence of therapies now in 2014?
Right, so we have a number of ways of deciding how to fit the drug to the patient. We don't really have a molecular marker, but essentially it's prognostication based on a number of clinical factors, things like anemia, performance status, calcium levels. There's certain routinely available clinical factors that we use to put patients in risk groups, high risk group, intermediate risk group, and good risk group, and then we decide based upon which risk group they fall in. Essentially for the good and intermediate risk group, some patients are candidates for high dose IL-2, patients that are younger, good performance status, and majority clear cell component. I think those patients would qualify for high dose IL-2. That's a very small proportion of patients because of the toxicities of high dose IL-2. Occasionally it can be deadly because of the leak syndrome, pulmonary leak syndrome, difficulty with lung inflammation and other organ inflammation. But barring that small proportion of patients with good and intermediate risk disease, you essentially have a choice between sunitinib, pazopanib, and or bevacizumab plus interferon. You also have other drugs out there for which we have lower level of evidence. Patients with high risk disease has 3 or more of those poor risk factors. Temsirolimus is the drug for which we have the most evidence. That's an intravenously given drug, and it's an mTOR inhibitor, which is a slightly different mechanism of activity, but it somewhat has a similar anti-angiogenic activity as well as some direct anti-cancer cell activity. So that's first line. Second line, patients post sunitinib, pazopanib, one of these VEGF inhibitors, you have a choice between axitinib and everolimus. We don't really know what the perfect way of sequencing is. People go based upon comorbidities, based upon the way the patient's progressing. Patients progressing slowly on a VEGF inhibitor, you might think that switching to a VEGF inhibitor, like going from pazopanib to axitinib, might make more sense as opposed to somebody progressing rapidly. But that's not clear. It's not clear at all that that's the right way to do it, but we sometimes use clinical judgment since we don't have a perfect answer.
Perfect. Well, Dr. Sonpavde, thank you so much. I think this has been a very productive interview.